cut. Here we are, our first remote recording, episode 18, and this one is, we're thrilled to be a media partner for Asembia 2024.
Yeah, it's a prescription for access on the road.
Here we go. Watch out.
Bob Hope's coming by.
Watch out, America. Here we are. Well, we're thrilled. Our first guest is hopefully our new partner, Melissa Paige, president of the National Association of Medication Access and Patient Advocacy. We're thrilled that Melissa's joined us. So welcome, Melissa.
Thank you, guys, and I am so thrilled to be the first one to test this out, so I hope it's recording.
Well, Melissa, could you just start us off by telling us a little bit about your organization?
Yeah, absolutely. So our organization focuses on those healthcare workers, medication access coordinators, biologic coordinators, anybody who is navigating that access to care on treatments, therapies, any product after that clinical decision has been made, right? So prescriber prescribes how he would like to, and we champion with all of those resources, tools, besties, we call them field reimbursement managers, key point of contacts along the way. So we provide that collaborative community education resources. We've got an app both on Android and Apple that is broken down by therapeutic area. And I think a lot of these challenges really go across everything. A start form is a start form. Right. Just insert your disease state and, is it outpatient, infusion, inpatient? So it's great to finally have a place. I came from University of Virginia Health System, ran that for 10 plus years, and I felt pretty siloed on some of these challenges. And everybody just saw, Melissa's getting these patients on treatment, but it was a very broken Band-Aid process that I ran pretty efficiently on 20 spreadsheets.
Right.
So, getting
Only
together.
not the fax machines.
No, we won't. And, the fax machines that ate page 5 out of every package that I sent. But so we've been doing this since 2020, and it has been great. We are finding kind of a home and a place for these people to understand, like, who do you need at your table? Who do you need to invite into your health systems and not lock out? Because we shouldn't be. We should be utilizing these resources and tools, and just the, payer partnerships, everything that you guys have to bring to the table. And I'll say, anybody supporting the patient access journey is what this organization supports.
Including podcasters.
Yes.
There we go. Well, no, we're very aligned with what you're doing. So thank you for the work you're doing. Thank you for fighting the fight. I think we're all on the same team trying to make a difference for patients. So what brings you to Asembia 2024? What are some of your goals here?
So this is my 8th year attending, and it's kind of gone through my whole journey of working at the hospital, finding different things here for that, going into my other roles. But my goal here is to find every partner supporting the patient access journey. And is there some way that we can partner, or do they have tools and resources that are just not getting to the appropriate people? Do you have offices throwing away your start forms because they don't even know what that is, or all of these things that these different companies are investing on? So I'm just here to build relationships and to continue those relationships, because I think what ends up happening is the face-to-face is where new ideas, new partnerships. I mean, right before this, we were just talking a little bit. So here for information, what's kind of happening, and bringing that downstream.
Well, we're only about halfway through the conference, but is there anything that stands out to you thus far, and people you've met or things you've seen, new ideas?
I am seeing a lot of new hub support models. Everybody is using the buzzwords that we love to hear of white glove touch, small, nimble, and talking with all of them. And I think what I'm hearing from a lot of my counterparts who are here is they are trying to figure out how to do this in the best way possible, which partnerships. And we go from this, hey, let's get on the biggest, largest hub, but you've only got 3,000 patient population in the US, your rare disease. Yeah. And you've got a budget, you've got to have these things with actionable data and reports. And so I see from my end, I'm just interested, like, what's coming out to support these patients and other newer, easier things to help out our patients and the healthcare workers. So maybe they don't have to be on the phone so much, or tracking down a signature that Mary doesn't have an address for because she's still homeless and trying to figure out these different things. So just partnerships. I think the hubs, I went around and there's some newer ones that I haven't seen. So everybody's trying to get into this game and it's great. Let's just try to figure it out together.
Yeah, there's a lot of need, right? So I know that you also had a session here at the conference. Can you tell us a little bit about that?
Yeah, absolutely. So the session is actually tomorrow, but what we're going to be talking about, it's a part 2. We did part 1 last year, and it's on the Inflation Reduction Act. And I'm excited for this year because we've got October right around the corner. You know, in similar fashion, we have somewhat direction, but not all of the pieces. And the panel that we have put together with HealthWell and Orsini and also the health system portion, you know, I'm representing those medication access coordinators helping the patient, but talking about like all of these different things. And my biggest question is from implementation, if there's a foundation open, I'm going to enroll that patient, right? But what does that do for smoothing and how quick can I turn on and off so patients don't receive bills? You know, there's going to be a lot of paper manual things that we've gone away from years ago with a lot of these foundations. And I think things are going to slow down, and health systems right now really aren't supporting on what this is or how it is. So we do with everything. Something gets implemented and we just hope to call our field reimbursement managers, stumble through and try to figure out this workflow. So I think addressing these things upstream and making everybody in that audience think like they're going to be getting a call from somebody or someone, patient engagement lead, on this, and you know, how can we help? So I'm excited for the discussion, and I know a lot of people have things, but we just need some toolkits out there, right? The people who are the next closest supporting, which then makes access to that medication a lot quicker.
All right. So in addition to changes in the environment like the IRA that you mentioned, and the challenge of coordinating across complicated processes like that, from your organization's perspective or your members' organization's perspective, what are the other key challenges and barriers in accessing medicine?
It's still identifying accumulators, maximizers, and now we throw in alternate funding plans.
Yeah.
And not knowing how we should push these discussions in a way, especially with alternate funding plans. Like there's this whole back war going on behind the scenes that we can't see. We're just trying to get a patient on treatment. We're seeing start forms and copay programs starting to remove certain things like their amounts for the patient that they give out. You got to call in. But even with the alternate funding plans, like PAP, that was never the goal of patient assistance programs. And you know, when you're getting sold these health plans or trying to make sure you've got 900 lives you got to cover in a school system, they don't understand all these intricacies.
Sure.
And so for us, we're on the other end that a patient comes through and we're like, sorry, you know, this drug isn't covered. Let's figure this out. And then we find out there's nothing covered, you know, and what type of plan. So being able to identify and, you know, these big name payers that I won't name, there's so many carve outs. And even the people on the phone when we call for case management or onto the payers, we're like, can you please read the bottom box? Does this have to go through a PBM? Is this white bag? Is this, you know, inside? Do we get it shipped? Like, how does this work out? So I think just the navigation of that prescription, and it's not necessarily even the authorization being hard now. The authorization is easier. This is the challenge, right? We got the auth. That's just the beginning of the starting line.
Right.
Yeah. Where do you get it filled? How do you get it filled? Is a specialty pharmacy going to kick out because that reimbursement isn't as good? And do I got to find it? And, you know, home infusion, and especially with rare disease, you know, nobody wants to pay for it. Well, you know, when these patients come on, but the navigation and being able to get these patients treated. So especially talking pediatric.
I have a follow on you mentioned the accumulator program.
Yeah.
And we did an episode earlier on that topic, and the accumulators were, you know, ruled as illegal or not, you know, comporting with the regulations. But I've been reading reports that folks are still using it, and that that rule has not been really enforced by government officials. Do you and your organization have any visibility into that dynamic?
So we work really closely. I think one of the best organizations following this, especially in Wisconsin, is the rheumatology group. That is, yep. She spoke at our conference last year, Madeline Feldman, and we are now having to figure out, like, okay, they're not abiding by what they said. Now what do you do, right? We thought this was a good check off, but you still have to press and report, and who's going to pick up the phone and make that decision, or why something isn't being implemented the way it is. Or, I don't even understand how companies are not getting penalized or what that looks like. But what do we need to do if we identify something that should have been good for a certain state or a particular area? Right. So I think just being able to have education around what do we do, and Madeline Feldman does great. Lots of resources in the room space, but we work really closely with them. So it's,
so we can't declare victory yet.
No, we're not. We it sounds like you've been listening to the podcast. So because these are the issues that we're tackling.
Every episode, every 17. Is this 18?
It's number 18. Okay. You're right. All 17.
I role play really well. I'll listen to every 17, but I will at the end, and you can quiz me.
But and as you know, because you've listened to all 17, that we ask all of our guests, what is their prescription for better access? So for you, if you had a choice to be in charge and just sort of map out how we can do something to help patients improve not only access but affordability, what would be your prescription for better access?
My prescription for better access would be a start form that has signatures on separate pages with your language on the 10th page that it can throw away. Electronically, right? This means through a cell phone, through signatures, something that we're already utilizing right now. The signatures is the hardest part. The income verification, let's get everything packaged up front. But if right, you really don't have to do a benefit investigation if a patient doesn't have insurance. So let's make it smooth and easy. Get everything that you need up front in the smallest possible way on the length of paper so people don't get intimidated like that. And let's promote what services you get behind that and do more upstream education, not when people are already upset and things are on fire and they don't know why they can't talk to their field reimbursement manager. Also, I think education for the health systems you've kind of got 3 pillars, maybe a couple of them. You got your sales side. You've got your field reimbursement, which I don't think that people are utilizing them in the way that they could be, along with their hub support, right? That we don't have all the time in the day, but explain what this gets me, where they are here, what it's going to save, and working internally more with our revenue cycle at every health system or even within any system of there should be no denied claims. And so, have these follow-ups, get that field reimbursement manager and go through 50 claims with me and let's figure this out. We should not have to be writing off anything and sending patients to our Thursday court that the particular health system I had mapped out so patients didn't show, to start forcing these bills everywhere. And so I would say from that side, and I'm going to take a lens from kind of the hub side as well, have options for your stakeholders that you're supporting and let them understand if they want to do a internal hub, right? So nobody wants to take on that legal point. So you guys have the footprints, have it available. How do you want to do this? Do you want to start with us taking on all the case management and down the road when, your forecast is a little bit better, you're meeting goals of transitioning, move along with them? Because I feel like right now it's jumping into another and building out that kind of playbook. And I don't think anybody's doing it really well for rare disease. And that's where we're kind of going, right? Gene therapy, things are being more expensive on things. So I'm giving you kind of all angles on here from an access standpoint. Some good practical
tips, I think, for how to make the process better.
Well, also
take advantage of the resources, that exist today.
Yeah, and she mentioned also, of course, the collection court, because we've heard over and over through the episodes that the patients are the one that ends up holding the bag, right? So you're right. There shouldn't be a denied claim because we should do the work up front and make sure that that it's known and the patient knows what they're signing off on.
Well, out-of-pocket estimates, let's talk about that. We can't guarantee anything. And when they're coming to us and we're that phone a friend within the institution or private practices, and we can't even tell them what they're going to be paying because they have a $0 or $5 copay card in their hand, but they don't understand that may not apply to administration, all these other fees. Like, patients are really trying to understand how much is this going to cost me, and why are we letting people go home with the car that of their choice, and then they get the bills after, or they get what that's going to be. So there's my analogy. So.
Well, great. Well, thank you. Thank you to Melissa Paige for joining us from the National...
For the work you do.
And from the National Association of Medication Access and Patient Advocacy. And we're thrilled. We're thrilled, and good luck tomorrow with your session. So
right.
Thank you for joining us today. Okay, Scott, we're back with two more guests, and this is
still from Asembia, Mark.
Still from Asembia. And we are. This is a topic that caught our attention because it involves specialty drug design and
benefit design.
Yeah, benefit design. Yeah, specialty drug benefit design. Thank you. And that's been a recurring.
It sure has.
So today we're thrilled to have Renee Rayburg, a pharmacist who's Vice President of Clinical Strategy with Pharmaceutical Strategy Group, and Morgan Lee, PhD, Senior Director Research and Strategy with PSG. So welcome Renee, and welcome Morgan.
Thanks so much. Thank you.
So can you just share with us what brings you here to Asembia?
Absolutely. So I'll share, we have a session coming up tomorrow on our Trends in Specialty Drug Benefits report. It was released on Monday. It's an annual report that we've been doing for several years, so we're really excited to bring it back to Asembia. I think this is 3 years in a row or so at Asembia. So, yeah.
Terrific. And have you, I know we're only partway through the session, the conference here today, but have you had a chance to attend some of the sessions, see some of the folks exhibiting here, or meet with people? Has anything really caught your attention or enthusiasm about what's going on at the conference?
So I would say how insanely large this conference is.
It is
right?
something, isn't
right,
it?
Right. So I feel grateful to be able to be a part of this, right? But what has caught my interest is the ability to network and connect with people in the industry that, otherwise I may not be able to see personally, right, or in person, right? So made some really great connections. We have, a few meetings and things set up, and then having the sessions to go to as well is great. So.
Yeah, awesome.
Well, that's great. Yeah. So I want to just go back real quick to your session and the study that you released on Monday. Can you tell us sort of where you were last year and what you learned this year and what some of the key trends are?
Absolutely, happy to. Well, so I'll start with one of the key topics that we looked at this year and that you'll see quite a bit of in the session tomorrow is on biosimilars. So we've had a few questions in the survey about that one for a long time. We added some additional questions this year specific to Humira biosimilars. Obviously, that's been a major event that's happened here in this last year since we had done our report. What was really interesting to us was watching payers kind of struggle along with how to handle biosimilars. So a lot of them are saying they want to use the lowest net cost strategy. When we actually ask about what they're doing, are they putting Humira biosimilars in preferred positions, things like that? Very little of that actually happening, especially in the employer space. So it was really interesting for us to see that. We have some questions in there about cell and gene therapies, obviously amazing clinical opportunities there. Financially, another big challenge to face in that regard. And then some other topics that we've been following for a number of years. So one of them is alternative funding. Those are programs that get a lot of attention. And we actually saw a little bit of a decline this year in use and exploration of those programs.
Good to hear.
And we saw a continued lack of belief in the sustainability of them. So that's been a consistent thing over the last couple of years as we've been surveying on those programs. Renee, are there other things you want to add?
Yeah, so the biosimilar topic was really interesting to us because there was a large percentage, especially when you look at employers compared to health plans, that were unsure of certain things. So, 44% I think were unsure as to whether or not they added a high and low WAC versions of the biosimilars. And then we had an open-ended question as well. So really interesting to read the open-ended responses. But one of them was how much the payers are depending on their PBMs for the strategy, right?
Yeah.
So while we know that, I think it's just, it's a challenge, right, in the industry. And, going into April, brand Humira still had about 96% of market share. So wasn't moving much. It will be now. PBMs are making some changes in that.
Yeah.
I would say that. And then the other thing that is important to mention, the top goal is managing total cost of care and then affordability. So those were pretty similar to last year. Those were the top two things. But their top challenge was having access to reliable data. So while their top goal is to manage total cost of care, but yet their biggest challenge is having access to reliable data, which inhibits the ability for them to do that, right?
Do you think with some of the transparency movement now that'll start to change?
Yes, and I think our message to vendors out there is when you have the opportunity, right, showcase what data capabilities you have, right? There's plenty of interest out there. And I think especially on the employer side, because usually they're dealing with multiple vendors, it's important to know what types of reporting you can get and what type of information they can help you with. And I think it's important for the vendors to know what their goals are, right? What the top goals are.
Yeah.
So and I know you've got a clinical background, right? You're a pharmacist. And so did the study evaluate some of the other hurdles that payers put in place, like prior auth and other things like that? And what did we learn about that?
Yes. So pretty much it's been very similar. It's been similar year over year, but the majority of whether it's health plan or employers are using prior authorization utilization management. And we have evaluated, we've asked questions about unintended consequences and things like that. But I think the overall theme in our perspective is people are comfortable, like the payers are comfortable with using it. They are paying attention to, if there's member disruption, if there's provider disruption, but at the end of the day, I think they're still pretty committed to using utilization management. I think it's important to ask the question. And also we asked a question about health equity, which we were really excited about because we think it's so important. But to us, the results were somewhat surprising because it was, the number of responses that we got in showed that while people are paying attention to it, there was not a lot known about it. And I think that so we're starting that conversation, but we need to pay a little more attention because it's complicated, right? Like our health system is complicated. It's, we think that maybe people in rural areas, elderly, they really struggle, right, with understanding their benefit, but it's really the average consumer is still having trouble as well, right? You've got programs like GoodRx where you can get drugs cheaper, right? Cheaper than your cost share. Like there's a lot going on out there. And so we felt like it was important for us to incorporate that in the study. And Morgan, you probably have
I would love to share more about that. Thank you so much for mentioning that question because we have been talking about social determinants of health and health equity in our surveys since I joined PSG. And every single time we're feeling this tension of they get that it's important and they're struggling with what to do about it and how to really have an impact. So this year in this report, the question was, have you seen any differential impacts to certain groups of members based on these utilization management programs that you're using? And only 1 out of 10 said that they had. And so to us, that number seemed maybe a little bit low, but it was, to your knowledge, is this happening?
Yeah.
And that goes back to those questions about data and are we actually tracking where disparities are occurring? So we're going to keep asking questions around it, but that was the question this year. And interesting, I won't say discouraging, but just a moment for more sort of education and data to be available so people can really see what's happening.
Yeah, very good. And Morgan, you mentioned earlier the alternative funding programs and utilization of those was down a little bit. How about the copay accumulators and the maximizers? Any data on that?
So we collect these data in fall of each year. So I'll stop and say that first. These data were collected in fall of last year. And we did see a slight uptick in reported use of those programs compared to the prior year. Not by a whole lot. It's hovering somewhere around 40 to 50% saying that they're using those strategies. So a small change year over year.
Gotcha.
So what about the topic related to the patient affordability? Like, is there anything that's covered there? Because we know that patients are picking up a bigger and bigger share.
Yeah, high deductible plans,
Yeah.
co-insurance burdens, those kinds of things.
Anything learned on patient affordability?
Well, so it is one of the top two goals. So affordability wise, right? I'm trying to think if there was anything specific.
Yeah. So when we talked about site of care, we asked about what their rationale was around their site of care program. And it was really interesting because they were looking at both the member aspect of it and the plan aspect of it. And when we asked specifically about what their priorities were for members, affordability rose to the top of that list, way above things like, we want to reduce their absenteeism or things like that. It was really, affordability was a top concern. We do have one other question, and I'm trying to remember if it's in this survey or the next one, I apologize, where we asked about sort of concern for those high deductible health plan members and saw a good amount of concern amongst those who have such members. So sorry, I'm not remembering all of the details right now. There's about 100 questions in every survey.
Like a great resource.
It is.
And we actually, in our session tomorrow, we are going to talk about specialty genetics, which is a topic that's kind of come out to the industry that really does go to that affordability piece of things, right? And so where, some of the big three PBMs are charging kind of higher costs on some of the specialty genetics when you could go to GoodRx and get them. So we have a slide that we're going to just kind of introduce the topic. But I think, knowledge is power, and where we want to get to with some of the other questions we have is like, how can we empower these patients, right, as consumers of healthcare, to benefit more from what's available to them, right? Bring more education out there.
And I will say, with respect to the member, disruption and dissatisfaction to the member was the top concern about those programs. Renee said it absolutely correctly. Still seeing a lot of commitment to those programs, but when they were giving ratings for a level of concern, that was the one that got the highest ratings. Yeah.
So if I could just pivot away from the conference for a second towards what your other clients, what you're seeing in the marketplace around patient access to drugs and affordability of drugs. Are you seeing other, maybe not covered in the survey itself, but again, like just other things you're seeing that the audience might be interested in? Because we're going to ask you also what your prescription for better access is. So before we ask you that question, what are some of the barriers you're seeing, or some of the issues that we could do to that we could eventually solve?
So I feel like it's a challenge because there's a lack of awareness of kind of what is out there. And so we've got a lot of these point solutions and some of these additional programs out there that are really focused on the patient. And so, with the clients that we work with, our clients are mostly payers, right? So, we have payers that are out, analyzing the options from their PBMs, right, that have discount programs. Some PBMs are offering where they're evaluating the lesser of GoodRx, usual and customary, things like that. But you've got GoodRx, you've got companies like Rx Savings Solution, which are, kind of member-centric, kind of evaluating, could there be a lower cost, blood pressure medication a patient could be on that patients aren't aware. So I think we learn a lot through that. And I think as we support our clients, so mostly benefit directors, pharmacy directors, things like that, especially on the employer side, we're trying to help raise awareness of, how can we improve that member experience and what's available to these, our payer clients to kind of help support that work and, get there. It's complicated, and I mean, and personally, I recently had an experience where, my 17-year-old had to pick up an albuterol inhaler, and I gave her $20, and the copay was $50. I'm like, $50? Like, albuterol inhaler? It's generic,
So
the
did you
doctor
pay
wrote it.
cash then?
Well, so what happened was she was there. She called me frantic that, they weren't very nice to her or whatever. So it turned out I looked up GoodRx and you could get it for $14, right? I went back and they wouldn't reimburse me because we had taken the inhaler out of the store.
Oh,
because she needed it or whatever.
Yeah.
But the bottom line is her mother, who's me, right, does this for a living, and was kind of, shocked at an albuterol inhaler could be $50, right? So it's the nature of our market, and I think it opened my eyes to, we need more education, right? We need to know what the cheaper options are out there, and that's really a lot of the key to the work that we do. We use data to identify what are those lower cost options.
We interviewed in our last episode the Antonio Chacha, and this, I think, was a great example of what he was talking about, money from sick people.
Right.
How something that really costs much less is being
Absolutely.
charged a higher price for somebody else who's
Right.
going to benefit from that.
Right, exactly.
And I'll say another one of our surveys, we've asked a question for a number of years about promotion of cost sharing transparency tools. And we saw a big jump from the late 2010s, so around 2018, to the last couple of years. And then it seems to have leveled off a little bit. But over half of plans are saying that they're promoting these tools. But when we start to dig into what tools they're using, a lot of times it's, well, whatever my PBM provides. And I think sometimes they may not, fully understand, is that really a high quality tool that is, being used? Not saying that all of them are bad, but just saying, to your point, getting that information to understand about that tool that you're using and whether it's really getting members the information that they need, I think is really
How
important.
much do you think goes to the transparency question, and how much of it is capability and sophistication at the employer or even at the insurance company level?
So I think it's a combination
Uh-huh.
of both. And I think a lot of it is lack of awareness, right, that's out there,
Yeah.
right? Because you're so busy managing your
Yeah,
plan
yeah.
and that you've kind of lost track over some of the more simple things. And we are really operating in this rebate-driven
Yeah.
kind of environment that favors the higher cost drugs, you
Yeah.
know, and it's okay because I understand the rebates are part of the whole picture, right? And there's savings that are counted on, and that's what drives lower premiums and all of that. But it just becomes so complicated that I think we've lost track of, and to be honest, I mean, sometimes we take a look at some of these generics, like migraine meds, like the generic triptans. I mean, most of them you can get for less than $10, and but yet what gets promoted are these expensive, newer, like branded products, right? And well, they are needed by some patients, but we can't forget about
Yeah.
what's affordable and making that awareness. We
Gotcha.
try to promote that in the work that we do.
So what if I could then also, why don't we pivot towards the, what would your prescription for better access be?
So mine would
Okay.
be to promote the lowest cost but most clinically effective drugs out there, right?
So a true low net cost.
Right. So, looking at, do you really need to pay for, like some of these newer branded products that come out there? Do you need to pay for a $500 blood pressure medication when you've got, a generic carb that works really well? So how can we maximize and position those products to be used optimally? Now, will they work for every patient? Maybe not, right? But right now, sometimes we're just skipping to that really expensive drug when a lower cost would, could work. And this leads into a lot of the work that we're doing now with Humira biosimilars. Like, it's interesting because Humira was the top drug for years and years and years, right? And so now we're hearing inklings in the industry that doctors don't want to prescribe it anymore. And I'm finding that hard to believe because if for patients that need a biologic, right, a TNF drug was the first drug you would reach for. Humira has been so popular. Well, you might be able to get Humira now for, if you get it at Cost Plus, you're going to get it for $500, right? You're going to get it for under $1,000. So to me, shouldn't we continue to start there, right? And then go to the, more effective drugs. So
Well, I mean, when CVS finally added the biosimilar to it, I think we did see that doctors were willing to prescribe it. And utilization certainly jumped.
that's correct, and that's the impression we're getting. Like, we work with some independent specialty pharmacies that have done some transition themselves, and they're telling me that 97% of patients and prescribers are comfortable transitioning.
Yeah.
Now, there's always a reason to make an exception, and I
Yeah.
support that.
Or
but,
start new patients.
Or start new patients.
Start new
correct.
patients
Yeah.
on the biosim.
Yeah.
Keep your.
But there's an opportunity there, right?
Right.
And same in like the MS category. We've got a lot of oral disease modifying therapies that are generic that are really low cost. So start a patient out on one of those products. Now, do they need, the higher cost branded drugs? They maybe do, but why not start, especially, and you can tell the doctors are evaluating the patients, how much disease activity they have, that type of thing. But you have these options now in these top categories where you can get savings, but you're not really.
It's a good example. The counter in my mind is that if you have MS, of course you don't want.
Oh yeah, you want the Cadillac. I agree.
Well, no, I'm not going to call it the Cadillac. I would say I want what's best for my health.
Correct.
Right? And if you're the doctor, you also want what's best, and the science there is evolving towards more aggressive therapy earlier,
Right.
more potent therapy, or
Right,
how
right.
more effective therapy, however you want to think about it, and all those patients are seeing, basically subspecialty doctors, right? They're seeing real experts, and so. So I do think like the low net cost. I like the low net cost thing, but the part on that pops out for me is really, Renee, more breaking free from the rebate distortion.
Right.
92% of the scripts in the U.S. are filled with generics. Maybe we can push that to 93 or whatever.
Right.
But
And I didn't want to be misunderstood, like I'm not compromising patient care, but
Yeah.
for the right patients where you can leverage some of these lower cost drugs, know that they're available,
Yeah.
right, and use them. And that's really all I'm saying. And so, in the right patient, now that you might be able to get Humira for less than $1,000, should it be considered?
Yeah,
Absolutely,
sure.
right?
Absolutely.
But it is
Yeah,
up
for
to the
sure.
doctor. We're not
Right.
taking away from
Yeah.
that. We're disrespecting, and I agree
Yeah,
with
we
the
just-
specialists.
I was just
Well,
saying MS is a more complicated
It is.
thing
It
than
is.
Humira.
Right. But
So-
there's availability of affordable drugs there.
Yeah.
Right. So I just want to turn to Morgan. What is your
Yes.
prescription for better access?
Oh my gosh, I think I may have to stick with what Renee said. That's really what comes out in so much of our research and our work. So, yeah.
Well, that's great. Well, then, thank you. Thank
We're
you.
all for a low net cost future
Yes, we
with
are.
with good access.
With good access and with the physicians being the quarterback on
Yeah.
your health.
Oh,
Right?
absolutely. Right.
I mean, that's, I think, what we all want.
Yeah.
Absolutely.
We've been around long enough to know managed care, like when HMOs were making decisions and we found out they weren't even trained in these, in some cases they weren't even having physicians evaluate these decisions. So, but hey, good luck with your session tomorrow.
Thank you.
Thank you for giving us a preview.
Yeah. Really important work.
Yeah, very
Fantastic
important
what
work.
you're
And
doing.
again, as we said, it's been a key topic on our podcast. So thank you to Renee. Thank you to Morgan for joining us.
Thanks so much.
Thank you for the opportunity.
Enjoy the rest of your time.
Thank you.